here, but I guess just to back up, so we started with our first iTrace maybe 2-3 years ago, and we were a little bit apprehensive because to us, in all fairness, the iTrace seemed like something that's used mainly in an academic setting and is mainly an adjunct to normal preoperative evaluations that would be, say, macular OCT, topography, something like that. But since then, we found it to be incredibly useful, and these days we don't go a preoperative exam without using an iTrace. So we're on our third iTrace, we're building an office here soon, and without the iTrace, we kind of feel like a fish out of water these days. So, we've talked a lot about iTrace in terms of cataract surgery, refractive evaluations, but I want to talk about a younger patient here. There's a game called Othello. You guys, I don't know if you know it or not. It's like a black and white checkers game that we had at my grandma's house growing up. It had this saying that was a minute to learn, a lifetime to master. And in all fairness, I think the iTrace has been like that for us. We use the DLI display readily. I think patients really get the idea of the cornea versus the lens. They get the total corneal power. They really understand that E. But I think for us, we've started using it for other things. We've talked about the toric check a little bit here today. We've rotated toric lenses. We had a guy with 9 diopters of astigmatism that, of all people to have a lens rotated, it's this guy. And so we had to use the toric check to rotate it, and it definitely helped us out there. But we've been using it for more and more things. We use the depth of focus curve these days to plan monovision. And I think this is a really unique case that illustrates just yet one other thing that we use the iTrace for. So again, this is a 24-year-old patient. We do a lot of LASIK and refractive surgery, and so this was a second opinion. It was a patient who had LASIK back in 2012 and came in because since that time she'd been having a lot of glare and halos, mainly just in the left eye. She said maybe the right eye a little bit, but really just the left side. When you look on exam, her vision's 20/20, refraction's essentially plano, and everything looks normal. Dilated exam looks normal, everything looks good. But she's bitterly complaining of glare, halo. She said, I just can't see at night. Her pupil's not that large, and really we were at a loss. So, we got an iTrace. So again, it's the left eye more than the right eye. But you can see on the right side, if you look at the Placido image down here on the lower left, you can obviously see that was it the red button here? Right here. So you can obviously see that we're dealing with essentially a decentered, nasally decentered myopic ablation from her previous LASIK. So no question that she's got a little bit of a decentered ablation, but in all fairness, this is not the eye that's bothering her. I mean, yes, you see the blurred E here. You see essentially a 10, which you'd expect for a 24-year-old, and then essentially a plano refraction. But again, this eye is not really causing her that much trouble. When you look at the left side, you have a whole different picture. So again, slightly nasally decentered myopic ablation profile. So no question that might be contributing minorly to glare and halos, causing this slightly blurred E here. But here, we've got a DLI now on the left side of 5. And again, on exam, the eye looks completely normal. And so we're scratching our heads. Without the iTrace, we probably would have started to go down the pathway of, well, you know what, maybe this decentered ablation is causing higher order astigmatism. Maybe we need to look at that in order to get her better vision. And the iTrace helped us to kind of zero in on the fact that something else is going on. And so here, if you look at the Chang analysis, again, here in the cornea, we've got some higher order aberrations. But then internally, again, this is a 24-year-old with a clear lens. So not only is there astigmatism, but there's some higher order aberrations here, specifically some coma. And so, we talked a little bit more. No history of any problems, no history of trauma, no family history of any issues. She said before LASIK, she thought that things were pretty good, but again, she was wearing contacts. She was a high myope, so it was hard to say. But again, we got something going on internally, and so Ray helped us. This was a screen that we previously were not familiar with. So looking at the wavefront map, so this is her left eye. So the right eye was essentially normal, but on the left side, so again, you're looking at this is the cornea here. So essentially, again, that nasally decentered ablation. But internally, obviously, you can see here what essentially is, kind of a flat area down here and a steeper area up top, almost like the lens is possibly shifted a little bit inferiorly or tilted. And interestingly, she had no history of trauma, normal stature. We weren't concerned about any type of genetic condition. The other eye looked normal. But clearly, there's something going on internally here with this patient. So again, back to the DLI display. So the iTrace can show you what happens if you shrink a pupil theoretically. Isn't that right, Ray? You just, I don't remember where the button is there. Maybe you can, or maybe it's not on here. But we essentially use the iTrace to simulate what would happen if we pharmacologically shrunk the pupil on this left eye. And even though the DLI won't change, what you'll notice is that if we shrink it 1 millimeter and then another millimeter, even though the cornea doesn't change, obviously, we've significantly improved the vision, at least theoretically. And so, again, this is a 24-year-old patient. We can get into a discussion about why her lens is the way it is, and we've looked at it in an anterior segment OCT, and we've referred her for evaluation. But, you know, where the rubber meets the road is this patient's not seeing well, and nobody wants to go in the eye of a 24-year-old patient with a clear lens. So what we did is decide to give her some, I think first we thought about pilocarpine, but we didn't want to give her a headache, so we gave her some Alpha-GAN. She called us that evening. I was like, oh my gosh, thank you, I've been dealing with this for so long. She's like, it's 95% better. It's not completely better, I still have a little bit of halo, but it's so much better. And so without the iTrace, we probably would have started looking at this decentered ablation. We might have gone down this pathway, we might have looked at topography-guided treatments to help improve the vision. But with the iTrace, it helped us correctly diagnose that the lens was the issue and help fix the problem in a reasonable way without being too invasive. So again, just yet another way that for us the iTrace has really helped, and I think we'll just continue to learn from it over the years.